and others. You know, it's important to pay attention to like common things. I'll point them out on there. Once again, certain patients present or certain classic presentations. So like elderly, we think about hip fractures, whether that's, you know, that's usually somewhere on the femur or the femoral neck, somewhere in that area. Dislocations of the hip are commonly tested on like board exams and which direction they lie. So it's important to remember like which one's a posterior versus anterior. And hopefully I can clear it up a little. The other ones on here, you know, I'll point out some of the more common ones. So we'll work our way down, starting with the hip. As with all of our fracture lectures, neurovascular exam first. We want to make sure they have distal neurovascular sensation and vascular status intact, and it's even more important, especially when we're talking about the lower extremity, because you know femur fractures, tib hip fractures, we certainly can lose a pulse there. When we talk about like knee dislocations, that's like the most common orthopedic vascular damage that you see, so it's important that we're checking that lower extremity. We'll talk about some of the different things we do, but always get x-rays. If we got to reduce it, get a post-reduction x-ray. And we'll talk about some of the times we want to get a CT as well, and that's usually if it involves a joint, we recommend getting a CT with it. All right, so things like to conceptually understand with lower extremity, we have some certain structures that get some of their strength from like certain rings, like we talk about the pelvic ring a lot. So we kind of differentiate some of these structures, like depending on how many breaks there are, fractures in that ring. So one's usually not too significant. We're talking about the pelvis. But anytime there's more than one, then we worry about the overall stability of the pelvis. So usually those are going to require surgery or be a lot more significant depending on the patient population. It requires usually high energy though, unless it's a very elderly patient with a fracture just from like falling or osteoporotic patients. Other things to think about are like the mortise, so the ankle joint is an important one, and any disruption in that little mortise in there, that part of the little ring or a half a ring on there. We worry about the stability, so we'll talk about the different fractures and which ones we worry about. Requires a lot of energy for some of these, especially like femur fractures are going to require quite a bit of energy to cause. So usually we catch these like in the trauma bay when they present. But we may see some, low energy, especially with those osteoarthritis or porotic patients. And then one of the key things to always remember, especially with femur and when you got like femoral neck fractures, we worry about like osteonecrosis in that proximal femur. Anything in the joint, you're probably going to run the risk of secondary arthritis. Either way, whether we fix it or not, and then we worry about joint stability for all of these. So once again, joint above and below. What's above the hip? Yeah, the back, the spine. Sorry, I'm taking a check off real quick. You guys actually have a decent head in here. Just wait till next semester, you'll understand. All right, so our neurologic exam, we want to consider certain things, especially with our hip dislocations. So our most common is going to be like a posterior hip dislocation. We can have sciatic nerve damage, impingement. So once again, important to get that neurovascular exam. Anterior, we run the risk of femoral nerve injury. Then around the knee, we got that tibial nerve. And then we get, when we get in that popliteal area, that's going to be our most common like arterial injury. So it's always important to remember that and some of the criteria we use if we suspect it, which is, you guys know, have you guys learned like what ABI is with the ankle brachial index? So yeah, it's important we get an ABI on anybody we have a knee dislocation with. Anything like 0.9 or below, then we want to get a CT angiogram on those patients. But for imaging, we usually get 3 views. Images for most of these or almost all of these, sometimes tip fib and maybe a 2 view, it just depends on where you're working and what you can order. And then special views, we have pelvic ring, you have certain midfoot fractures, really it's weight bearing, like Liz Frank is one we always worry about, and we'll talk about that coming up. And like I said earlier, our ankle mortise view is important and we need to check our measurements on there and whether it's intact or whether we see any difference. And then CT, anything at the joint, or anything you can't see on X-ray. And then MRI can sometimes be more sensitive for like occult fractures on there. We'll talk about some of the time frames. So here's our time frames for like stress fractures or occult fractures. So plain films can take a while because we have to look for that like bone remodeling on the X-ray, so it takes time to see it before we can catch it if we don't see it on the initial film. So we can do a bone scan, which is going to be the fastest, or it's going to show up sooner on a bone scan than the other test. Gold standard is always MRI, but it can take up 48, 72 hours roughly for an MRI to find that stress fracture. But it's always important to remember those. I don't know how you get a bone scan that soon, but I mean, we always teach it, talk about it. I've tried to get one, and it takes forever. So just like for almost all our fractures so far, if they're not involving a joint, there's, it's stable, non-displaced, no neurovascular deficits. We usually can treat them with like non-weight bearing. And we'll get into the details of the different stress fractures, whether it's on the compression side versus the tension side here, and which ones are important to remember for like femur versus our tibia, or some of the ones we worry about the tension versus compression side, because one you can heal with non-operatively, and the other one needs operation. Then stable, minimally displaced. Sometimes with pelvic fractures we can treat them as long as there's only one fracture along that ring, non-operatively. But most of them will probably be treated operatively, and then our incomplete fractures like torus and green stick. I want to say I just had a torus, and I think like the latest guidelines, like you really don't have to do anything for them. Most of the studies kind of don't show any difference whether you splint it or not, so we just give them one of the pre-made splints for those nowadays, so we don't even cast them or anything like that for those incomplete fractures. And then operative treatment for femur, you can lose a lot of blood in the femur. I think the slides might say like 1.5 liters. Sometimes I've heard like up to 4 liters can bleed into the upper thigh, but it all it all kind of depends on the patient's size, body habitus, things like that. And then, when we're talking about the femoral neck, anything involving acetabulum, we want to, or any pelvic fractures, they need to get operative management. Then open syndesmotic injuries, because we run the risk of articulation between joints and those two bones staying together, and then non-union osteonecrosis. Any joint 2 millimeters step off, and anything like unstable, displaced that we can't reduce. And then one of the things that's important to remember is our different risk factors with some of these injuries. So we'll talk about DVT or venous thromboembolism a lot next semester, and you guys will scan. That's why I wear the scrubs. We're doing scanning all for our classes for the senior semesters and looking for DVTs and things like that. But we run the highest risk with like any sort of inability, or if they're non-weight bearing or not ambulatory. With a femur like a femoral neck fracture, they run one of the highest risks for hip and femur fractures for DVT. So it's always important to remember that adverse outcome of it. So anybody with those fractures, we want to make sure we anticoagulate them while they're in the hospital to avoid a DVT. And then same things for like non-union, malunion, or adverse outcomes. That's why we have follow-up repeat x-rays. And then you can always have hardware sticking out. Any sort of neurovascular injury, wound, infection, which you guys talk about, surgery next semester, and then same referral decision. So open, neurovascular injuries, pathologic fractures, non-unions. Some physeals, but dislocation of the hip. This one requires usually high energy trauma, and sometimes in elderly with some sort of prosthetic hip, you may see it but usually it's going to be a high energy motor vehicle accident or like a significant fall from height. When I do my fellowship or when I work at BAMC, I'm always amazed at how many people fall off a ladder every single day. Like it's like mind blowing. I don't know if we just build a lot more here, but it's kind of crazy, and a lot of them are drunk as well while they're working and roofing. So you see a lot of falls. 90% are posterior dislocations. What's important to remember is how that extremity present. It's one of the more commonly tested on the boards. It'll be on your test here. So, easy ways to remember it. Yes, you need to know like short, flex, adducted, internally rotated for posterior. But in real life, when it's like internally rotated, we just kind of assume it's a posterior dislocation. Anterior dislocation is going to be externally rotated, it'll be flexed, abducted. And these ones are big, so we need to check that neurovascular status on these. So our distal perfusion and sensation, we need to make sure they're intact. And it's probably not going to be intact because it's dislocated. So something to think about. These patients, they need to get it reduced as soon as possible. So our greatest risk, like what we worry about is osteonecrosis of that hip if we don't get it reduced soon enough. So you're looking if they can get it, less than 6 hours, it's usually like a 10% chance of osteonecrosis, and it increases every hour. Every hour after that, you have a higher risk. Like 24 hours is like around 50%. So we need to get that reduced immediately. And then if there's no complication or associated fracture with it, then we can have the patient, we put them limited weight bearing with crutches for the next 2 to 4 weeks until we can ensure that it maintains stability and doesn't dislocate again. Anything that has a fractured aspect with it, we want to get them to surgery. It's involving a joint. And then if there's any bony fragments that are impinging anything in that joint or its function, they need to get operation too. But once again, we worry about that osteonecrosis of the hip, so it's always important to remember. Same with, our DVT risk in these patients. We always want to consider that if they're going to be non-weight bearing or bedridden. Did you guys learn about your Wells criteria and all that fun stuff yet? We talk about it next semester. You guys probably briefly covered it in the overview, but it's one of the highest risk factors we have there. All right, moving on to the femoral shaft. These are usually associated with higher G trauma. There's concomitant injuries with it. So this can be a fall, motor vehicle accident. Saw it a lot with blast injuries in Iraq and Afghanistan when I was there. What's important to remember in this, you can lose, many liters of blood in that thigh or that femoral area. And so you can lose pulses, neurovascular status. So we need to reduce that or provide traction on it as soon as possible. So we have a nice little traction splint example on there. That's not definitive management, that's just temporizing until they can get, typically like an external fixation on that and align the joint back up. But that's one of the crappier traction splints, but it's a little portable one that's easier to carry. But there's a lot of different models out there. Somebody will provide manual traction until we can get that on there out in the field, and then once we get to the hospital, we'll place one on there. It's usually a little better until we get them to surgery. Most of these, or all of these, are going to get some sort of operation with it. So we do our temporizing measure with our splint on there, traction splint, and then we stabilize and they get surgical intervention. And they usually do like an X-fix, so they'll put pins in there that'll stick out, and it provides that skeletal traction. They usually put a rod in there like you see in the picture on the right-hand side as well. And it's pretty brutal watching these, so you guys are probably watching on phase 2. It's like, dude, they have a hammer and they look like carpenters and they're banging rods into people. It's kind of wild. All right, our pelvic fractures. So once again, usually like motor vehicle accidents, they get, side swipe. We see these a lot. In the elderly, like osteoporotic, just a fall from standing can cause this. So we need to consider it in those patients. And one of the keys to remember, like the femur, you can lose a significant amount of blood in the pelvis. So a lot of what we deal with in trauma will have either a pelvic fracture, some sort of internal intra-abdominal hemorrhage in there. And one of the things we have to do for these patients is stabilize. So we usually put them in, to a splint initially once they're in the ER or a pelvic binder, initially to help reduce some of that blood flow. One of the things like for physical exam, a lot of times in trauma, we say don't rock the pelvis when you're palpating because you run the risk of causing a more significant bleed. So we just kind of gently palpate onto them and just provide one like downward movement when we're assessing for instability of that pelvis. So we don't want to rock it back and forth or cause any more further damage. And then, you know, neurovascular exam, which can be difficult to kind of assess when you're trying to stabilize these patients with significant fractures. But you have all your spinal nerve roots running through there. But you got to remember all of like, you know, cauda equina and everything else is back there, so we want to assess those. And then if we have any, a lot of times with pelvic fracture, we can have bladder injury as well, and urethral injury, so we always want to look at the meatus for these patients and look for any bleeding from it, especially prior to putting any sort of Foley catheter in them. So we know that most of these patients are going to surgery with these fractures, so a lot of times we will place a Foley catheter in them in the trauma room just because they're going straight up to the OR. And these ones we want to be careful before we do that. We'll get a retrograde urethrogram prior to inserting any sort of Foley catheter in them, so that's another concern with these pelvic fractures. And then, like it says, adverse outcomes, so GU injury, high VTE risk, or venous thromboembolism, DVT. And then one of the permanent neurological injuries we see with this is going to be our sacral plexus injury or lumbosacral plexus injuries, just because you have a plexus running through that area, possibly where the fracture is. So they can have permanent neurologic damage for the rest of their lives from that. So it's always something to consider. That's why it's good to get a neuro exam before we do anything. But once again, it can be kind of difficult when we're stabilizing these patients, just based on the mechanism of how many other concomitant injuries they have, because, you know, we want to make sure we save their life, because, you know, it doesn't matter if they have neurologic injury if they're dead. All right, so very rarely do we do like non-operative. We tend to look at if it's one area of that pelvis and like those, in a patient that had, you know, isn't obviously an athlete or, you know, providing a lot of weight bearing in that area, we can do non-operative treatment. But most of the time they're going to get operative treatment. So this one would be like, probably a non-op would be somebody with a significant number of comorbidities that we don't want to take to surgery because the risk of surgery is probably worse than the risk of them fracturing it. So those are like the few times we would probably do non-operative management for these. But anything unstable or high energy, we need to stabilize them first, and then they need to get this fixed. And there's a picture of like the pelvis binder on there. You can use a sheet like in the top picture. They all work just fine. All right, moving into the proximal femur. So these are another one common in the elderly. This is usually what kills them. When they have a fall from standing, they fracture that proximal femur, usually somewhere in the neck. Because they're not ambulatory, everything kind of spirals out of control after that. So, you know, it's a pretty significant injury in those elderly patients. So we always want to consider this. You know, higher risk or risk factors are like white women, older, sedentary, smoking and alcohol can cause it. And then anybody on psychotropic meds because they fall a lot more. Anybody with dementia, osteoporosis have a higher risk of this. So we want to make sure we differentiate these different regions on here for where the fracture is and kind of how we treat it. So we look at it like the femoral neck, where we consider it intracapsular. So those are usually a higher risk for adverse outcomes. So a lot of those will get surgery, or all of them should get surgery if it involves that intercapsular area. And then extracapsular may or may not be treated with surgery. So here's a test you can do. That femur fracture kind of presents similar to like our anterior dislocation look. So it's short, externally rotated and abducted. One of the tests you can do is like a little log roll of the hip there, and if they basically move in one of the feet in the femur, and you're kind of moving it in internal rotation, external rotation. If they have pain there, that can be like a subtle indicator, especially if we're not sure that we need to image or not. But most of them are going to get imaged. We have pretty low threshold, especially in our elderly patients. And then they won't be able to perform a surgery leg raise. All right. So, yeah, most are going to get operative repair, especially intercapsular. If, like I said, if they have any risk factors, they may not, or if they're non-ambulatory, maybe something we don't do anything for, we treat it non-operatively. And then, you know, most of these are gonna get surgery. Once again, we need to worry about, you know, venous thromboembolisms are big. And then anybody who's bedridden runs the risk of like pneumonia, decubitus ulcers, things like that. All right, stress fractures. So these are hard to, these can be difficult to diagnose. That's why we talked about like when a bone scan can see it versus imaging, versus X-ray versus MRI or different types of imaging. So we see it a lot in athletes, especially in like basic trainees who, you know, weren't as active prior to the military or anybody carrying loads. We'll see in runners as well. We can see stress fractures, especially when we talk about like our female triad later with our like amenorrhea, anorexia, and everything. But what we want to consider is whether it's tension versus compression sided, so that changes our management for these patients. So anything, tension would be considered on the superior side, so you can kind of see the fracture line in that picture. And it's not completely fractured. Anything on the tension side is going to be, runs a risk of completely fracturing and displacing, so those are going to be managed a little bit more aggressively versus the compression side. And here's some imaging on MRIs. There's a bone scan on the bottom right. I don't expect you guys to be able to read MRIs. Make sure you can read X-rays, that's important. But you can sometimes see very subtle lines, like even on an X-ray, depending on how long they've had the pain, you might see like some radiolucency, sclerosis, or some new bone if it's been a few weeks afterwards. But bone scan is going to see it the soonest, and then MRI is still the gold standard for the most sensitive for a stress fracture. So if we suspect one, we want to make sure we check what side it's on, and then some of the patient factors like age and comorbidities on those. But if it's non-displaced and it's compression sided, that one's going to be treated a little bit differently. So we want to have them stop activity, no weight bearing until the fracture's healed for 6 to 8 weeks. So they'll get serial X-rays, and they'll have close follow-up. And then if the fracture isn't progressing, we can continue that management, or if it is, they need to get operative repair. Anything on the tension side, it gets operation. So those ones have a high tendency to displace. We need to be concerned for those tension sided. So don't send those ones home. Those ones need operation. And then moving on to the knee. So just kind of like we talked about humerus, we have like our supracondylar areas can suffer a fracture in the distal femur as well. And one of the things we consider is, you know, the location and any joint involvement. So you can see kind of a 3-part or more of like a wide fracture in that middle image there versus comminuted. These ones, like something important to think about is like, you know, a car bumper hitting someone's knee from the outside can cause some of these fractures. Tibial plateau fracture, something we always worry about in these as well, with that valgus force impacts that area. We can see that tibial plateau fracture. So we always want to consider that, especially in like our motor vehicle collisions, if they have knee pain associated with it. And then our elderly patients, we see it in as well. For these ones, we want to make sure we check an ABI on any of these fractures as well, just like with our our knee dislocations. So we need to make sure that they have it neurovascularly intact, but we need to get an ABI on these patients as well. Anything below 0.9, we need to get a CT angiogram for those patients and look at that vasculature for disruption. So once again, you know, start with our X-rays. Anything that's inconclusive or we think is involved in the joint, we get a CT scan for them. If we suspect, if we can't see it on the CT, or if we think we need an MRI. The thing with MRIs is they're not like emergently ordered, so it's kind of hard to get one, a semi-soon time frame. Like I think here at BAMC, they're looking like 3 months in advance for MRIs. And then if it's, non-displaced, minimally displaced, not involved in the joint, we do that partial weight bearing with crutches for 6 weeks. Anything displaced, open, involved in the joint, popliteal or vascular injuries, they need to get an operation. All right, stress fracture. So, we see a lot of, tibial stress fractures, very common for shin splints to come in. So, we see it with trainees. You'll see it a lot with, soldiers who are ruck marching a lot. Some people with like incorrect biomechanics, you can also see it with hormonal imbalance, vitamin D deficiencies, osteoporosis. This is similar to like our femoral neck fracture. So we look at whether it's a tension side versus a compression side. So initially we'll get x-rays for these. This is where a bone scan can be helpful if it's early on and we're trying to determine it, if we can get it quickly. And then MRI can still have false negative results depending on the time frame of these patients. So for non-operative, like a mild, what we consider mild, is they don't have pain at rest, pain only with activity. So I only have pain when I'm ruck marching and running. Those can be managed non-operatively. Any pain with walking, we want to put them in a cast and limit their weight bearing. And then once pain's resolved, they can resume normal activities. Any anterior tibial stress fracture, we want to get an operation or surgery on those ones. All right, moving on to the femur, pediatric femur, and we'll go through some peds ones. So, when kids are like extremely accident prone, so we do see some of these fractures in kids. What we worry about, or what you should always think about, especially in those younger ones, is non-accidental trauma. So it's something we always want to think about with these patients. So obviously if they can't walk, they shouldn't have a femur fracture, so that's indicative that they're probably being abused at home, and it's something we always want to look out for. And it's something we think about a lot in the ER as well, but anything, the younger they are, the better chance they have of healing. So a lot of those, we're just going to cast them, especially if they're non-displaced, anywhere really on that portion of the femur that we're concerned for. And then anything that's displaced or trochanteric, or the femoral shaft in older children, we look at doing operations for those. And then anything distal femur, because you're running into that joint down there, those are going to be operative repair as well. So pediatric tibia, similar to an adult as well. One thing we need to think about with all of our tibial fractures is going to be, it's probably our highest risk for compartment syndrome. So we always want to make sure we're checking those compartments, feeling if they're tense on exam, or if they have, everybody remember all the P's and everything? Like the pain, pain out of proportion. And really the first one's most likely going to be that pain out of proportion that you're going to see. Pain with, you can have passive extension pain, tense compartment, paresthesia is usually a later finding, and then pulselessness is usually, extremely late finding on these patients. But we want to consider doing, checking those compartments, doing a good neurovascular exam. For the tibia, if we suspect it's involved in the joint, we want to get a CT on those ones. If it's distal tibial fractures. All right, we're gonna, I think, move back into adults here, lower. We're gonna move more distally on our bones. So we have certain fracture dislocations of the midfoot that we have to make sure we always think about. So Liz Frank fracture, it's technically considered a dislocation of that tarso-metatarsal joint, and it can cause like some permanent disability later on if we miss these. So you can kind of see that joint space widening there on the right side, and it has that articulation with the joint. So any widening there, we need to be concerned for these fractures. If we have like let's say, there's somebody with midfoot pain, maybe trauma, and you do that metatarsal squeeze test, we need to order weight-bearing films, which normally for acute conditions or trauma, we don't order weight-bearing films. So if your x-ray is inconclusive, they have pain, when on that squeeze test, we need to get a weight-bearing in these patients is like the key difference, because we can't rule out that Liz Frank unless they're applying weight on there. But it's one of those can't miss diagnoses that's commonly tested. And it will be tested here too. All right, so what do we do for these? If it's not displaced, most of the foot, like, you know, if it's not displaced, we don't do surgery for those. We could put them non-weight bearing, like 6 to 8 weeks in a cast. Then they have to wear like arch support for 3 months after casting. Anything displaced or involving more than one of the bones in there, we're likely gonna have to go to surgery so we can give them more support in that foot or midfoot. Then the ankle. So this is a very common one. So it's important to remember like how our ankle fractures, you know, can affect the stability down there, or what we call the mortise. So the mortise is that little portion where, let me see. Turn my thing out in here. So like the mortise is considered this little portion here that kind of goes around. So anything involving the mortise is usually a more significant fracture. We won't, you know, we won't like test you on the different types of fractures and the Webers and the type A's, but this is something to think about. And ortho uses those like really to help decide which ones may maintain integrity of that mortise. So stable versus unstable, just like a pelvic ring, if we have, you know, one side versus both sides of the joint are, you know, can be more concerning and unstable if it involves both sides. And just like we did with that physical exam yesterday, we want to check for that high ankle sprain or high ankle fracture, which is a Mason-Ooth fracture. So that one's going to be like your medial malleolus. So a more significant injury of that ankle versus just like your normal inversion ankle injury, which is very commonly seen. So we need to check that proximal fibula for a fracture as well. So plain films are going to be our best way for evaluating these patients. If it's involving that joint or the mortise there, we sometimes get a CT with it. We need to make sure we evaluate that proximal tibia for a Mason-Ooth fracture. And then if it's stable, one-sided distal fib, we can do a weight-bearing cast. Versus anything unstable or involving more than one side of that mortise, will likely have to do surgery on those patients. But there is like a Weber criteria, so, and it's really, it categorizes it A, B, C, and so it's below the syndesmosis. We can normally treat, that's normally a stable fracture, distal fibula. We can treat it with weight-bearing, a weight-bearing cast. When it's a B, it's at the syndesmosis level, so it may be stable or unstable. So we have to assess that medial side, and then Weber C is above the syndesmosis. And we consider those ones unstable, so they'll almost always get an operative repair, but you all need to know that. But when you read some of the x-rays, they may call the Weber different type in there. Usually they're pretty lazy and they just tell you where the fracture is, and then you have to decide, but it's something to always keep in the back of your mind. Moving on into the foot, so calcaneus fractures, that's like, requires a significant mechanism. The calcaneus is pretty strong bone, especially because it, tolerates the weight bearing all day. So in these patients, we need to make sure we rule out spinal fractures as well, because that energy can travel from the heel up to their spine. So anybody with calcaneus fracture, we need to, look at their mechanism. And rule out like a spine fracture with it, especially those falls and motor vehicle accidents. And then most of these are articular, so they'll usually require operative repair or some sort of pinning, since it's going to involve the joint in this area. Other important like stabilizing joints is going to be our like navicular bone, so those ones will get a pinning as well when we have them displaced or when they're fractured. But all of these are usually going to get operative repair. Then they'll have like a initially we can put them in a splint, elevate ice, the usual things we do rice therapy, but they need to get surgery usually immediately for these kind of fractures. So this is one of the few we call ORTHO 4. One of the other things to consider is like the talus in the foot has a limited blood supply, kind of like your scaphoid. So that's another consideration as well. It has a higher avascular necrosis risk, so it's always something to think about with a fracture of the talus as well. And then our Jones fracture, or our fifth metatarsal fracture, that's one of the more commonly ones tested as well, and we need to know it. This, you can get it with just like an ankle inversion injury, which is why one of the ORTHO criteria is tenderness over that fifth metatarsal. So we want to make sure we're evaluating that and ruling out one of these fractures. So we have, depending on where the fracture site is, whether it's a zone 1 versus zone 2 versus zone 3, it's different management. So a zone 1 fracture, we call it a pseudo-Jones fracture. That one you can see on there involving just the close, really it's not involving the metaphysis or diaphysis. So you can get something subtle like an avulsion where it's just a small piece kind of pulls off there, and versus like anything lower or more distally, we worry about that Jones fracture, so they require different management. But like a zone 2 Jones fracture requires more extensive mobilization. So normally with most of our foot fractures, we just put them in a cam boot or a walking boot. We need to consider different management for like a zone 2 Jones fracture. And then, so they'll a lot of times have to be casted non-weight bearing versus our cam boot. But, so zone 2, we do a non-weight bearing cast for like 6 to 8 weeks. If they're athletic, they might get operative management. And then zone 3, we see it more with like stress fracture, but it does have a higher chance of non-union, delayed union. So those are all going to get operative repair. And then, like I said, zone 1, we usually put them in a cam boot. They can weight bear as tolerated with it versus our zone 2, which is the Jones. That's non-weight bearing in a cast, 6 to 8 weeks. Once again, we always worry about compartment syndrome in that lower extremity. Anything with multiple metatarsal fractures, we worry about like stability and long-term arthritis risk. So that's going to be, referral to ortho. And then zone 2 and 3 Jones, we refer to ortho or open fractures. Toes, we don't do anything for the toes unless it's the great toe. So I get like a lot of complaints in the ER. A lot of people stub their toe and they're like, all you did was just tell me to put tape on there. I didn't even need to come in. And I'm like, yeah, you probably didn't need to come in. But so we don't do a ton. We don't put them in a cam boot or anything like that for our phalanx fractures. Usually we give them a hard sole shoe, or what we call a surgical shoe, which I think maybe there's a picture of on the next slide. Similar to the fingers, we want to look at any rotational deformities on there, so those might require like us to reduce those prior to sending them out or doing anything. So those are one of the times where we do a little bit more and we reduce that into the anatomical position prior to putting any like buddy taping or splinting on there. One thing to consider when we buddy tape, we want to put something between those toes so that they don't return later for like maceration in between the two toes. And then anything involving, the great toe has a, significant like stability risk, long-term risk of osteoarthritis with it. So those are going to need to be referred to orthopedics if we have any fractures in those. So we kind of already talked about the sesamoids. Now we'll talk a little bit about fractures. So we got those two little bones that provide some sort of structural integrity or whatever they do there. In my opinion, they just irritate people, but they are surrounded by our flexor hallucis brevis. What is concerning for us when we worry about a fracture is whether it's a bipartite sesamoid versus a fracture. So, we can do, we might have to order some different scans if we suspect this. Most commonly, it's going to be the more medial sesamoid, this fracture. And you can see with hyperextension injuries, usually it's from repetitive stress in athletes is what we see it most with. So the key thing for this is like a bone scan. So if we suspect a fracture there, we don't see anything on x-ray, or the x-ray shows a bipartite sesamoid, we need to make sure we get a bone scan on these patients. So a cold bone scan is a bipartite, and then a hot scan is going to be a fracture in those. We can get an MRI on it as well, which just shows usually edema in there. Sometimes you can show an old healed fracture, so it can be helpful for patients. Treatment really is weight bearing, put them in a cam boot, and then progress to a stiff-soled shoe. Then they got to wear a metatarsal pad for 6 months afterwards till the fracture is clinically healed. Anything with if it involves a plantar plate fracture with plantar plate rupture, then they would do operative repair. Once again, we worry about adverse outcomes with this, so like that hallux rigidus, just because of the healing time and the limited movement we have in that joint. And then stress fractures of the foot, we call it a march fracture because you see it a lot with people marching or walking or carrying loads, people who are rucking a lot. We also see it in like young women with that female athlete triad, so it's important to remember that, like amenorrheic, osteopenic, and then they have some sort of disordered eating or anorexia associated with it. That's always a consideration. Like I said, you got classic patient presentations. This is one of them. And the most common is going to be that second metatarsal. Most of these are going to be, non-operative. So put them in a cam boot. Weight bearing is tolerated. If there's any associated fractures, or if it's like a calcaneus or fibula, stress fracture, those are managed similarly, as long as it's not completely through the bone. And then navicular is going to be non-weight bearing, or that fifth metatarsal, just because of that risk of non-union in those due to the blood supplies a little bit less. We worry about like osteonecrosis, non-union. All right, I know it was a lot. You guys don't seem to have a lot of questions normally. What questions y'all got? Yes.
For patients with calcaneal fractures.
With what?
The patients with the calcaneus fractures.
Yep.
If they don't have any complaints of any like low back pain, like movement, they have full range of motion, you still get the molar X-ray just to pull out.
No, so yeah, it depends. That's why like mechanism is important. So if they don't have like the appropriate history of fall or motor vehicle accident, they're not having back pain, it's appropriate, obviously not to order the imaging of the spine in those patients. And that would more commonly we see that with a stress fracture. It typically doesn't, your calcaneus typically doesn't fracture from minor trauma. What else? All right, well, let's head down to the lab. We'll meet there at 11. We'll go through some foot and ankle exams. I got sheets up here if y'all